Welcome back. This is Mina Malapeti with another episode of the Seamless Connection podcast. And today I'm thrilled to have with me David Fletcher, who has been working for over 2 decades in healthcare and most recently was at the Geisinger Health system, refining and expanding their telehealth system throughout their central Pennsylvania region. And previously he was at the University of Arkansas for medical sciences, also expanding and projecting out their reach for delivering healthcare services to the populations most at need. David, thank you and welcome to the show.
Oh, thanks so much for having me, Mina. I'm very happy to be here.
Can you tell the audience who isn't familiar with your work and your time in the industry what you've been up to for the last 2 decades and what's brought you to where you are today?
Sure, yeah. So, really a lot of focus on, kind of transforming care. And one of the major tools I've been really working in is kind of digital health in general and a lot within the telehealth space as well. And so, in Arkansas, we really, at the time, we had one academic medical center. It was located in Little Rock, Arkansas, right in the center of the state. We had 75 counties throughout the whole state. And so, but so many of the subspecialists were located only in Little Rock. So, for instance, the program we started with was really a maternal fetal medicine specialty program for telemedicine because all 4 MFMs in the entire state at the time were located in Little Rock. And so all the other areas of the state didn't really have access to that subspecialty care unless they had the means to get, maybe 2-3 hours away into Little Rock. And so, that really, really was a light bulb moment for me of really understanding how, gosh, some of this technology that's coming out can really help, mitigate some of these traditional issues we've had with disparities in care based on whether you just happen to live in a big urban area with lots of very well-educated subspecialists, or whether you only had access to primary care, or in some cases only, a family practice, physician or PA or something. And so really have been working a lot in that space, and then was recruited to come up to Geisinger and lead the telehealth program. So at Geisinger, the great thing that I found about that was Geisinger is a fully integrated health plan. So they've got health plan and hospital, and so that opened up a lot of possibilities for what we could do with telemedicine. So in Arkansas, we were a little bit hamstrung in that it was largely fee for service. And so a lot of things that we could do, like to decrease unnecessary transportation, things like that with telemedicine, just didn't make sense in a fee for service world. And they did make a lot of sense when we were both the payer and the provider. And so, really did a lot of work there, headed up the EICU, the in-hospital, in-clinic, in-home, virtual nursing, all that kind of those efforts at Geisinger. And then most recently, I've been working in consulting and really passionate about trying to, really extend the things I've learned and mistakes I've made, and have those learnings spread out across the country or even across the world to the greatest degree I can. And one of the things I'm working on now that I'm really excited about is I'm working with the West Health nonprofit organization out of California who really advocates for the aged, and it's an area of telemedicine that I think is really unfortunately often underutilized because people have some assumptions around older patients and their use of telemedicine. And so working with them to really advocate and talk about how telemedicine and digital tools can be designed with the aged in mind, and they actually get enormous benefit out of it. And in fact, they have a pledge that I encourage folks, if they agree with me, to go sign this pledge that the Center of Excellence for Telehealth and the Aged. Just Google that and you'll find they have a pledge that basically just 32 organizations have already signed up, and to really show that they support making sure that we keep the aged in mind as we build these kinds of technical advancements.
No, that's fantastic. And I want to go back and double click on a nuance there that you brought up, which is in a fee for service system, sometimes the benefits of telehealth aren't fully captured, aren't fully realized even, versus a kind of comprehensive closed system like a Geisinger. And my question to you is, can you explain that to our audience a little bit in more detail, in the sense of what benefits do you see with telehealth period, and what isn't, or what is missed perhaps in a fee for service world that maybe isn't, fall under a distinct CPT code or a distinct bundle or what have you, and that you are able to see the benefits of from when you look at it holistically, that we should be considering perhaps more broadly.
Sure, yeah. So, an example of a program we were really excited about in Arkansas that never went anywhere, and I knew a lot of other folks in other states who had kind of the same experience, was, we thought, well, telemedicine would be this great way to avoid having an unnecessary transport from a skilled nursing facility. So oftentimes, a resident at a skilled nursing facility, nursing home, will end up getting sent in an ambulance to an ER for a fairly minor type condition, just because the nursing facility may not have the kind of medical expertise they need. Or at the very least, they use a non-emergency transportation, which sometimes might not be necessary. So we thought telemedicine is this great solution. We can beam in a specialist, talk to it's way better for the patient. They get to stay in place. They don't get jarred and trying to go into transportation. The problem was that Medicaid traditionally pays for the skilled nursing facility stay. Medicare traditionally pays for the ambulance. And so, even though both partially federal programs, Medicare entirely, Medicaid partially, they were different buckets of money. And so we could go to Medicaid and say, well, we can save the transportation costs. And Medicaid would say, of course, they were in favor of it, but they were like, it doesn't come out of our budget. We can't fund it. And so just those kinds of weird, kind of perverse incentives ended up being stumbling blocks. Whereas for Geisinger, for instance, Geisinger was also the payer in many cases. They had a large Medicare Advantage program and things like that. And so it was worth it to the health plan to cover all kinds of programs like that, just to ensure that we were decreasing the total cost of care. We weren't so concerned about which bucket it was coming out of.
No, that completely makes sense. In terms of just understanding the differences in care and the nuances in care versus what people might think the aged need, what do you think that the stereotypes are? And I know I'm thinking of some off the top of my head, of course, but I want to make sure that we capture all of them. So what do you think the stereotypes are with how the aged think about or relate to or use telehealth versus what have you found in your experience?
Absolutely. I think so. One of the a phrase that I often use is like this old kind of quip that it's not the things that you don't know that get you in trouble. It's the things you know for certain that just ain't so. And I think one of those things that falls into that bucket is that telemedicine is great for millennials, Gen Y, people born with an iPhone in their hand. Of course, they're going to love telemedicine. That's the right audience for telemedicine. Older folks, they're not going to like it. It's not what they're used to. And there's just a certain intuitive sense to that a lot of people kind of latch onto that and assume that that's the case. And in fact, we have not found that to be the case. We've done a lot of surveys, satisfaction surveys about telehealth, and we do it across a lot of ages. And it's particularly important for Geisinger because Central Pennsylvania skews older than the general population of the country.
When you say older, what do you mean?
So the 65 to 85 is much larger than just across the U.S. population. And so when we surveyed them, we found that their satisfaction rates with telemedicine were basically identical to the general population, the 0 to 65. And one thing that was interesting was at Geisinger, we found that the 65 to 85 population had a higher satisfaction score than other 65 to 85 across the country. Not dramatically so, but noticeably. And I think the reason for that was because we had to design our telemedicine program with the aged in mind because of our population. And so we didn't have an elaborate kind of portal or sign up process we integrated everything with the electronic health record. And so we were able to just send a link. We would send a text to their phone or an email, whichever they preferred, and the patient would just send a link because it was all, connected and integrated in the background. And so we knew who they were, and so they could just click a link and get into a secure connection. And so they didn't have to do a lot of signing up. And so I always laugh for the first 6 months after COVID, when telemedicine really exploded. Almost all of my survey responses started with the words "I actually," because everyone was so surprised at how incredibly easy it was to do. And I think that's why really everybody of all ages, but I think particularly if it is someone who's older and maybe has not necessarily been using a smartphone their entire lives. So I very very strongly always push back on folks who assume that, oh, certain demographics, whether aged or other racial or socioeconomic categories, are or are not a good candidate for telemedicine. You can't tell from any of those things, and based on any of the survey data that I've seen.
So it sounds like the takeaway there is if you make it simple enough and easy enough and straightforward enough, maybe
Mhm.
for them to use or for anyone to use, they're going to use it, which is kind of a takeaway for any age group, right? So that's awesome.
Absolutely, exactly. That's my argument. Is I think a 30-year-old, even if they had the technological savvy to get through it, they'd rather have the easy solution. I know I would.
Yeah, I was like, I can't even imagine, like, I can't even remember the number of logins that I have and the passwords and all of that. Whereas if I just had a link that said, hey, at 2 o'clock, click this link, I would be happy to do that.
Absolutely, absolutely.
So you did a lot of work with Geisinger and building up telehealth as you did in Arkansas. And specifically, there was some astronomical, I think it was 200 fold growth in telehealth. Obviously, COVID happened and there was a lot of growth driven by that, which accelerated a lot of things. But you obviously took a lot of initiative in putting together ways to facilitate that growth. What would you highlight as like the top three things that you did or that Geisinger did more broadly to drive that astronomical level of growth? I mean, it's not that you guys were behind the ball in the first place, right? You were already kind of pushing the limit. So what else did you do to incrementally and dramatically increase so quickly?
Yeah, no, it's a great question. So one of the things that I think really set the stage for us was we had built a single platform to handle all those modalities. So in the past, a lot of times you'd find Geisinger itself and any other health systems I knew of, there'd be kind of one solution for in the home, and then they'd buy another solution for hospital-based stuff, and then they'd buy another solution for remote patient monitoring, and you had kind of this hodgepodge of systems. And so fortunately, prior to COVID, when I came in, I said we're going to have a single platform. We're going to build a lot of integrations with our EMR, and so that our providers, regardless of what specialty, what modality they're working in, they're going to follow the same process. Now, I'd love to say I was clairvoyant and I saw how important that was going to be. I absolutely did not expect anything remotely like COVID. But I will say, I mean, even before COVID, we'd grown from before I came to Geisinger, they were doing about 100, 150 visits a month across about 20 different specialties, and we'd grown to over 800 visits a month, which at the time I thought was, wow, what a really nice growth pattern. And then, of course, the very next month when COVID happened, my growth was completely washed out by, because we went 50,000 visits or something. And but I think that was key, and especially because on the provider side, it made it so easy for us to stand up across. We went from 20 specialties to over 70 specialties in a matter of a couple weeks. And the only way we were able to do that was because it was the same process for everybody, every specialty. They didn't have to worry about, well, is this a hospital? Is this a SNF? Is this a ambulance? It was the same platform. So that was key. I think the standardization, and it also, of course, made it very much easier for the patients because we didn't have to worry about like, okay, log into this portal if you're from your house. Otherwise, you're going to be using an entirely different process. So that was one key. I'd say another key was we took a lot of survey data and we learned a couple things. So in addition to the high satisfaction for other age groups, um, one thing that we did find, and there was an age difference in this response. Um, Very high satisfaction for telemedicine. We asked them, okay, great. If we can get to a post-COVID world, what are your intentions to continue using telemedicine? Now we had well over 80%, maybe I think over 90% satisfaction. I assumed that it would be somewhat similar. It was only 62% actually indicated that they intended to use telemedicine going forward, which puzzled me because I thought, well, you love it, why wouldn't you want to keep doing it? I mean, I should have known, but we asked then, okay, well, what are the things you like about telemedicine? It was the usual things you'd expect: convenience, I don't have to sit in a waiting room, etc. Um, and then we asked, well, what concerns, if any, do you have? And one of the number one thing that everybody said, and it was particularly pronounced amongst the older patients, was, I don't know that this is a medically, thorough exam. Is it as comprehensive as an in-person exam? And we were grappling with that question, but honestly, mostly with the audience of policymakers and healthcare leaders in mind. And I think we kind of skipped over, our patients are asking the exact same completely appropriate question. So we kind of had to pivot. We were so focused on, hey, look how convenient and easy this is. We also had to add in additional information for our patients about when we offer it, and equally importantly, when we don't offer it. So, we did a video with one of our pulmonologists, who's a great champion for telemedicine, and he talked about, some of the great instances, but he also talked about, look, there are times when I have an exam that I can't do via telemedicine. If that's the case, we don't even offer it to that patient. We say, hey, we need you to come in. And I think, that really helped to alleviate some of the concerns. So I think, really getting that feedback from the patients and adjusting the program based on that was another big key as well.
We have algorithms throughout so when we have our telemedicine platform, and similar thing, the biggest driver of success is we're getting rid of point solutions, and we're also seeing patients appropriately, so you're not doing a double visit when you're like, oh, sorry, I couldn't actually treat you, you have to go back and see someone in person, right? So I think that level of communication and explanation is definitely something that is easy to skip over, definitely easy to skip over, and easy to miss. But once you did do that, did you see a different, like, what happened afterwards? Like, did people stick with telemedicine for something? I understand, like, once the hospital's open, once PCP's office is open, maybe some of them go back naturally, but did you stick with that 60% post COVID, or was it higher? Was it lower? How did it end up working out?
Sure. So I'd say once the clinics reopened, we very quickly went down to about 12 to 15% of all of our outpatient visits, which is pretty much in line with a lot of other kind of leading health systems that I knew of. And now, but it varied widely by specialty. So, for instance, behavioral health, of course, kind of the gold standard. We 60 to 80%, I know over 80% actually of outpatient behavioral health that we completed over telemedicine. So, and in fact, yes, we found that as we kind of pivoted the messaging, that our patients were very comfortable with it. Really, the main thing that was driving the adoption was the providers. Now, interestingly, often, mostly appropriately so, we would ask the providers which visits can they do clinically and which they can't do clinically. I think there's still a lot of data to be looked at there as well. I think we need to help support our providers with some really good research in that field. But the other thing that we noticed was even within a single specialty, we have enormous variance from provider to provider, and they were seeing the same types of patients, same conditions. So I think there is still definitely an element of just provider preference, and I think that as much as anything drives a lot of the patient comfort with it as well.
No, that makes sense. And as like you said, you had a huge proportional and disproportional impact on Asian populations in Pennsylvania. And as we all know, our population is getting older. It's going to be a situation that's probably replicated across the country in many areas if it isn't already. What advice do you have for people facing the same conditions, or soon facing the same conditions that you dealt with, which is an aging population, multiple comorbidities, I'm sure multiple specialty needs? Are there certain specialty areas they should prepare for Are there certain areas that can be done more in telehealth to kind of ease the burden of care on people and to get people more compliant? Because, I mean, I don't know about you, but with my grandparents, there's at least 1 or 2 visits a week, right, as they get older. So something like that, even if you're the most dedicated caretaker, can wear on people if it's always kind of back and forth and back and forth. So, do you have any tips or thoughts on for growing an elderly population with all that burden of healthcare needs? How do we appropriately incorporate telehealth and at the same time make people feel comfortable they're getting the health care that they need on a broad scale, specialty or otherwise?
Yeah, oh, absolutely. So, I really, I advocate strongly in terms of just a regular visit. Design your visit so that everybody can use it. So you shouldn't have just a whole separate flow of, oh, well, this is how we do for older patients and younger patients. It should be easy for everybody. But that being said, I think there is absolutely a need to be kind of think outside the box and be flexible. So like behavioral health, part of the reason we have such a high percentage is one, it's the visit itself lends itself. You don't really have to have hands on, of course, in most cases. And in some cases, we actually find that our providers think they get a better view because they're seeing how the patient is actually living in their regular environment. So it's kind of a win-win. The other big piece for Geisinger was Central Pennsylvania. It's really hard to recruit certain specialties to. There's not a big urban area here, and so we just flat out couldn't recruit enough behavioral health subspecialists. But with with telemedicine, we could enter into contracts with other geographic areas. I mean, there's a shortage across the country, but it does vary, and areas that had more available, we just had to get them licensed in Pennsylvania. We went through the credentialing process, and they were able to see our patients, and so we dramatically increased our access. So I think that's part of it is you can get access to a lot of subspecialists that you wouldn't necessarily in that area, which can really benefit the aged population. And then lastly, I really think that the one of the focuses that we really try to hone in on for our older population is just again that real ease of use. And so, like, for an example, is we have this program called Geisinger at Home, which we actually won awards for it. I was very very proud of it, but again, it's kind of outside the box. So the real quick version of it is we would actually send out a nurse or a community health assistant into the patient's home, and they would do all kinds of things. They would coordinate social services and make sure that these patients were getting everything they needed. And it was really geared toward exactly what you're talking about: patients who have multiple comorbidities, very high risk for readmission, for ER utilization. And so, and at the very beginning of this program, we would actually then, if that nurse saw something concerning, the physician would actually drive all the way to the patient's home. Now you can imagine that's a very resource intensive, difficult to scale type program. And so when I got here, I was excited about the program, and I thought we can make this really much more efficient. What if we send that nurse or that community health assistant out with a tablet and a MiFi? We don't even have to worry about if the patient has broadband. And then a digital stethoscope, an otoscope, a handheld camera. And so we would do that, and they would beam in the physician, and we were able to scale that program up very rapidly. And again, that's a good example where the fully integrated health system really paid off, because the health plan, even as resource as intensive as that is, taking all the costs into account, the health plan saved over $2 million a year because we were able to make such a dramatic improvement in hospital readmissions and ER utilization. So I think those are the kinds of things that we'll have to keep reconsidering as the population does get older, and really kind of design our programs with the patient needs in mind, and really think downstream about, okay, yes, this may be a costly initial investment, but what are going to be the benefits downstream if we can really implement this and make it an efficient program.
So you've had to fight that fight already, Right. And you've been in the midst of, budget talks and over the years. I'm sure during COVID was very different from post-COVID, from pre-COVID. But as we all know, hospital budgets are always lean and margins these days are thinner than ever. How do you have that conversation when, again, for many, they see it as a cost avoidance issue, not necessarily a broader benefit, right? And how do you frame it correctly so that when you are in those conversations internally at a health system, at a hospital, whoever's at the decision making table, that they understand the full value of what you're doing? Because at the beginning, I'm assuming, knowing how this works, that they see the cost. They see the cost of scaling the program, and they're like, this benefit might or might not happen. We might or might not have seen it in the pilot. So how do you get them over that hump?
Absolutely. Oh boy, that's a great question. And funny you asked that. About a couple years ago, actually, the we were a couple years through COVID, and the CEO of the health system called a meeting and asked me to attend, and asked me to kind of summarize what all we had stood up in telehealth. And I was enormously proud of, like, oh my gosh, well, let me tell you, like, we're in skilled nursing facilities, we're in ambulances, we're in prisons, we're in hospitals. And he said, wow, that's really, I didn't even realize the full scope of all that. That's amazing. So now that we've opened our clinics and things again, how do we know what's the right amount? Because like we stood all that up because we had to. We had no choice. We were closing clinics. Now, should we be doing more in certain areas? Should we pare back some now that we don't necessarily have to have it? What's the correct amount of telemedicine? And my honest answer at the time was, I don't know. So um, I realized, I was like, oh wow, okay, I almost wish I hadn't shut off my mouth about all the things we were doing. But it was great because then we spent the next year really doing like a deep dive into, okay, what exactly what you're talking about? What's the value that this is bringing? We kind of went about it backwards. Before that, we would always, we'd have kind of these little niche programs, and then we would predict and do the full analysis ahead of time and like, okay, should we do this or not? And in this case, we'd done it all already, and now we were going back and looking at the data and say, well, should we continue to do it? And it was a challenge because we had over 70 specialties, and so I was trying to figure out a way. Is there a way that there's just like one big answer, unified theory of telemedicine that this is why you should do it and the degree to which you should do it? And I was not able to come up with that answer. What I ended up having to do was break it out on use case and kind of broad use cases. And it wasn't my specialty because even that was going to be too granular. Like I couldn't do 70 different analyses and present that to the executive committee. So what I found was that they kind of did fall into different categories. So for instance, some specialties previously, because they were just, at least for our area, hard to come by subspecialties. We had them in Danville, which is where the Geisinger is headquartered. And so previous to this, they would actually send physicians in a car to, say, Scranton, where another one of Geisinger's hospitals is. And so that's 2 hours in the car, there and back, for a very expensive subspecialist that we have enormous wait times for. And so just a very inefficient use of that service. And so we're able to explain that, look, this makes sense because we're able to just really kind of, leverage this system that's being used in a lot of different ways. And so it makes sense if we can cut 4 hours a week of this very expensive subspecialty, that's benefit to the system. But in other cases, it was about improving access, like behavioral health. We can't get these providers here, but we sure can get them in California, and then they can beam in and they can cover our hours and things like that. So we really did have to kind of go use case by use case, and really look at it. And then the other example I always give is even in Arkansas, where it was fee for service. We worked with our legislature in Arkansas and actually passed a payment parity law, state law. And at the time, I was doing a lot of the business stuff for the group and the telemedicine group, and everybody said, "Oh, this is going to make your life easy, right?" And the simple truth was, it barely made a dent in any of my ROI calculations. The fee for service was so small comparatively, particularly like say for an MFM. An MFM is a pretty expensive subspecialty. So a $90 consult fee didn't remotely cover the cost. What the thing that was driving it was the downstream. And so that's the other thing I always tell people is, don't just focus on the fee for service or the, am I getting reimbursed for this one individual visit? So for in that case, it was, we had a very the NICU was a big cost or big profit center for the hospital, and so if we make sure we got the sickest of the sick at that hospital, then that is what kept the NICU going, and everyone agreed. The nice thing was everyone agreed. It wasn't like we were trying to take everybody's patients. Everybody knew like it was the only academic center in the state. Everybody agreed the sick babies should be there, and so it was really all about making sure that the sick moms who were going to have sick babies were being cared for by MFMs and then ended up delivering at the most appropriate location of care. That was what really drove the value for the program.
Yep. No, that makes sense. It's highlighting those key use cases as the examples of this is why you do this kind of more broadly. No, that makes sense. So now that you've kind of established such a successful telehealth program and also explored it with different populations, what's next for you? What are you thinking about focusing on? Is it more telehealth? Is it more work on the elderly? Is it more a combination of the two or something completely different?
So I'm really excited about just again continuing to try to transform care and improve access for groups that sometimes haven't had access to as good a care as we could give them. As a country, we have a lot of resources at our disposal, and sometimes they just don't get spread efficiently. And so I really think, of course, there's a lot of ink spilled on AI and a lot of concerns with it, and very appropriately so. But I do think there are a lot of things involved in AI that can be married with a lot of digital health tools that can really improve care for folks. So like at Geisinger, we even had a fairly simple version of it, but it was a symptom checker and a chatbot that we were able to use to help guide patients through. We have all these tools available through our website and patient portals and things like that. They're just hard to navigate through if you're not in healthcare every day. And so the chatbot was really good at helping patients guide them to where they needed to be, and then handing them off to whatever resource they needed, a physician, a clinician of some kind. And I think there's a lot of room for that. And then I think there's a lot of room also just to make providers' lives easier. That's the other thing. People ask me all the time about, well, how did you stand this up so quickly? And I think they're looking for kind of a magic, oh, you use this cool tool. And honestly, the biggest piece that I've always found is looking at what the provider is struggling with, solving a problem for the provider, because that drives so much of the kind of healthcare decision making. And so, I think there's enormous potential. I could envision a world where providers are talking to the patients either through telemedicine, which is a great, or even in an exam room, and kind of some of these ambient type tools that can listen in and with AI kind of actually build out a full note and understand this is the diagnosis that the provider's talking about, and then eventually, again, way down the road, but that this just gets transmitted to the payers, and the provider is not spending 30 minutes sitting there typing in all the things they just learned from talking with the patient. So I think tools like that, I think are there's so much ink about, oh, a robot doctor is going to replace all the doctors. I don't foresee that happening anytime soon, but I think some of that kind of back end processing, I think, is very ripe for making providers' lives easier, I hope.
No, no, that's awesome. And then I'm excited to see what you end up working on or consulting on next. I know you've got a lot of great ideas from what you've seen already and what you see as a potential for the future. So looking forward to connecting as things go forward.
Thank you very much. Yeah, it's an exciting time. I really appreciate it.